in type 2 diabetics with this metabolic syndrome, I personally don't focus on any targets. I believe that statins in these people are used to target the plaque which creates the cardiovascular or a macrovessel event, rather than any targets which are always subject to change. And as you know, recently they've been revised to a lesser level. The reason I say that is that there is evidence based on various large trials like CARDS or ASCOT, that if you focus on just being on a statin rather than chasing a certain target, like in heart protection study as well, then the lesser the LDL, the better the outcome. So with every 1% drop in the LDL, you improve the situation by 1%, and same for HDL, but the other way around. So my target will be a robust, effective approach in terms of these people with type 2 diabetes, making sure that they are on a statin, and if they are being protected in a primary sense, we reach the current targets, which are total cholesterol of less than 4 and LDL of less than 2. I think various audits, as you quite really alluded to, the number of people reaching those targets suggest that if you take an average practice in this country, then about a quarter of the people who initially are supposed to be on a statin get to the target, because it's like a rule of halves really, that the half get their cholesterol checked and then the half get started on a statin and the half of that actually get to the target. And that was the data from a few years ago. So I think in answer to your question, not more than 50% of the people with 40 milligrams of simvastatin will reach that target. In terms of the CORF of 5, I think it's a target based on evidence, and also it gives a mindset into the general practitioner or the practice nurse that they need to aim for a certain target, which in a sense will mean that more people will get started on a statin and more people will be pushed towards that target. I'm not entirely sure whether the target of 5 is really where the threshold should be, as I alluded to earlier, that in my opinion all type 2 diabetics should be on a statin irrespective of their starting cholesterol, and really one should aim for the lowest achievable LDL and total cholesterol rather than chase a certain top target. With regards to the JBS targets which have recently been published, and I welcome them because they recognize the need for the ultimate goal to be lower than it was thought originally. But I again will emphasize the point that it really, if you look back in time, these targets have moved several times in the past, but they carry one message. If you combine all the trials conducted with regards to statin therapy to date, there is one core message, that the lesser the LDL and the lesser the total cholesterol, the better the outcome. So I think in a sense it's a good thing that the targets have recognized that, but at the same time it might spare the people who are already below that threshold. People think that they would not require a statin. So do you see that the point I'm making is that here the statin is being used in the type 2 patients of mine to stabilize the plaque and protect them from a cardiovascular event rather than chase a certain target. The key factors which decide my choice of statin is the evidence base, followed by the benefit-risk ratio, the cost-benefit ratio, and the degree of compliance that the person will have with regards to the possible side effects. So really the first thing that I would look at is the evidence base, and I will follow that sequence that I just described. It is very important to look at the fractions of the cholesterol, and traditionally we haven't, mainly because of the availability issue, and not checked them. But I think, as you quite rightly pointed out, it has begun to, the message is starting to get across that the LDL, HDL, and triglycerides and intermediate density lipoprotein, everything has a job to do. It's just as important, although not as hugely evidence-based as lowering the LDL is, but I think increasing the HDL has its own merits. I think the factors dictating compliance to any medication is whether it is taken once a day or more than once a day, whether it is easy to take in terms of its tolerability, its side effect profile, and its benefit to the patient, because here we're treating a silent but deadly situation for the person, but we can create visible or appreciable side effects. So any drug which is once daily and is not causing a significant side effects would dictate the compliance of the person. The people that I use rosuvastatin are the people who fail to reach targets as defined by the latest total cholesterol less than 4 and LDL of less than 2 if it's a primary prevention situation. And in secondary care people, if the starting cholesterol level is exceedingly high, then I would certainly go for the most effective of the statins. I would also use rosuvastatin in people who cannot tolerate the other statin like simvastatin or atorvastatin. So that'll be my main area of usage. In terms of the limited outcome data available with rosuvastatin, one has to remember that there is outcome data of the lower the cholesterol, the better the outcome, which is really the message from every large study conducted to date. With the sudden epidemic, if you were, not so sudden, of type 2 diabetes and metabolic syndrome, I think there will be an enormous need for statins in the future. And as the data builds around rosuvastatin, that being the most effective, one would expect its use to increase. Personally, from my personal experience with regards to the efficacy of rosuvastatin, I have not encountered any major problems with its usage, and I have certainly achieved the targets I set out to achieve in most of the cases because the way of its pharmacokinetics are. I just think that we can't rely on anecdote, and we need to really be guided by evidence which is scientific and impartial and neutral. My personal experience of the safety of rosuvastatin compared to the other statins is that they're not dissimilar. There is lots of audit data from various parts of this country which is available, and that comments on that as well. I just feel that because of its effectiveness, it tends to carry this slight misapprehension that it will cause the problem. But all of my colleagues that I'm aware of use it quite frequently, including myself, and I don't come across any more problems than, compared to any other statin. The truth of the matter is that the incidence is not dissimilar to any other statin, and it really is in keeping with its effectiveness for its mechanism of action. Obviously, certain populations like the Asians or people with muscle disease or hypothyroidism will have to be monitored very carefully, and if there is open communication and indication to the patient to seek help in terms of muscle pains and aches, and there is facilities to monitor CK, then one cannot behave any different with rosuvastatin to simvastatin or atorvastatin. The main benefits of rosuvastatin to my clinical practice is that there is a significant chunk of my patients who need lowering their cholesterol, the total cholesterol, the LDL cholesterol, and raising their HDL, because in their metabolic syndrome, in terms of batting order, dyslipidemia really is the top abnormality, as recognized by the American Diabetes Association as well. So I would certainly use it in people who do not get to the desired target range, who are non-compliant or can't tolerate the other statins. As a patient, if my physician chose to treat me with rosuvastatin, I will make an inquiry as to is it effective, does it carry any more side effects than its fellow sort of sister drugs, and the answer to that is that it is just as safe and probably more effective than the others, and certainly I would have no hesitation to take it.